You're tuning into the O&P Check-in, an SPS podcast. I'm Brendan Erickson, a regional sales manager at SPS. This show brings you the latest happenings in the O&P industry. We're unpacking trends and news from this tight-knit orthotics and prosthetics community. Co-hosting with me today is SPS Sales Account Manager, Stephen Hunter.
Hey everyone, glad to be here.
Yeah, let's go. Let's get started.
Are you looking for a foot that keeps up with your K3 users? Willowwood's MetaFlow delivers with a 14-degree range of motion, a 95% energy-efficient carbon composite C-spring, and a waterproof durability to handle any environment. Designed for natural movement and stability, MetaFlow enhances mobility while helping reduce fall risks through active dorsiflexion. Say goodbye to energy dampening and provide power back into users' steps. Learn more and order today at spsco.com.
Enhance your savings when you shop with Rewards Online. Enjoy an extra 3%, 5%, or even 7% off. Explore the SPS online store and keep an eye out for star-marked products from leading brands like College Park, Prodior, and Oser. No enrollment is needed. Visit the Resources tab to browse the Rewards catalog or connect with your SPS Sales Account Manager for more details. Hello, listeners. I'm thrilled to welcome back to the show a special guest from Northwestern University Prosthetics and Orthotics Center, Associate Professor John Brinkmann. Welcome, John. We're excited to talk with you today about your recent article featured in the O&P Edge magazine titled Hygiene and Its Implications in the O&P Practice.
It's great to be back.
Absolutely. It's been too long, so welcome. We really appreciate you taking time and spreading your knowledge to us and all of our listeners. We really appreciate it.
Yeah, nice to meet you, John.
Good to meet you.
So before we jump into the article, could you just share a little bit about your own personal journey into O&P for our listeners?
Sure. I was born into O&P, got into it sort of the old-fashioned way. So my father was a prosthetist orthotist, had his own business that he started when I was about 4, I think. So that's all I really remember. I remember growing up in the facility, always being around it. And like all of my family members, worked in some capacity as a kid when I was growing up in the facility, and then decided to go to school. It was right at the time when they transitioned to a bachelor's level requirement for certification. So I went to UT Southwestern and completed residencies after that, and then practiced clinically for about 20 years before coming to Northwestern. And it's been 13 years since I've been there.
So, John, in your article, you mentioned an eye-opening encounter you had with a patient. Could you kind of talk about that early experience a little more?
Sure. This was during my residency right out of school in orthotics. And I'm sure I'd encountered some of this issue of poor hygiene prior to this, but it was about a year in. This was a particularly dramatic case of somebody who I think now we would say was a hoarder. I don't know what the technical term is for that, or was someone who hoarded and just had different characteristics, including lack of hygiene. What interestingly was a very pleasant person to work with. I actually enjoyed her coming in, but it was very distinct that there was noticeable signs of lack of hygiene. I mentioned in the article, because it was true, and it's a pretty significant detail, every time that I worked with her or her device, something alive would crawl off of her. So a bug of some sort. I'd always clean the device when she came in. And that's one kind of extreme example, but I think every clinician probably has those. That realization, I guess, early on in my career, they may not be a high percentage of our patients, but it is a very consistent issue. We all have someone that we're working with that has lack of hygiene as one of their presenting issues.
Yeah, that must have been a pretty extreme example if you grew up like in your entire life inside your father's clinic and your whole career kind of in the clinic. And that was a pretty drastic one, I guess.
Yeah. And I wasn't, as I was growing up, wasn't really seeing patients much. And that wasn't something I remember talking about. And I don't remember, kind of jumping ahead, like these extreme cases, there's usually other sort of compounding or complicating factors. And I just didn't know anyone growing up that
Mhm.
lived that way. So this was really my one of my very early exposures to that. I just found that difficult to deal with, more so in some significant ways than exposure we would expect to see in any kind of medical encounter or O&P encounter. So things like wounds or burns. So there's other things that I wasn't used to that took some time to adjust to. But this one, it never really, in my mind, I was never able to kind of reconcile, like, what should I be doing about this? Should I be talking with someone about it? If it's a wound, I can talk about how to protect the wound. Or I can realize it's not really in my scope. But with this issue of hygiene, it's affecting the patient often. It's affecting others who come into the facility. And then there's just my discomfort with it and frustration with it.
Do you think there's an aversion there to hygiene, or it's just kind of their normal instinctual way of living? Or I don't know, I guess we're just trying to get to the core of maybe why these instances happen.
Yeah, I think, and that's what I was looking for when I was, like looking through for some articles on it. And I wasn't actually able to find a lot of healthcare related articles on hygiene in the way that I was interested in it. So there's a lot about infection control, as you'd expect. So proper hygiene and limiting spread of germs. And there's some about mental illness and hygiene. And I didn't write a lot about that in the article because I don't want the end conclusion to be, well, anyone who has poor hygiene based on our standard
Right.
must have a mental illness. But that's definitely a factor. So there's a range, the way I look at it, of common hygiene practices. They may vary some and be on one end or the other of that sort of range, but most people make an effort to be clean and orderly when interacting with others. And it's the extreme cases where it's like this, there's something with this lack of attention to personal hygiene.
Yeah, it makes sense. Like culturally, I mean, you look back 150 years ago when running water wasn't a commonplace thing. Hygiene practices would be different, but there was still that cultural standard.
I always enjoy doing the background on these articles because I find way more than I can put in. But I talk a little bit in the article about historical practices. I sort of had this impression like, well, until, running water in showers, people, bathed once a year. And like, there's actually evidence that hygiene practices in general were more common than we tend to think, than sort of folklore says about, but clearly that there wasn't as much access to running water and things like that. But there's always been an emphasis throughout human history on purity and on cleanliness, and that could be moral purity that was sort of connected, or it could just be the way we think of it, cleanliness and hygiene. But that's always been acknowledged as part of interacting socially. Like we're communicating something about ourselves to others in how we take care of ourselves.
So, John, how can clinicians avoid biases about patients with hygiene challenges?
I mentioned in the article, Paul Ekman was a psychologist who started actually with the communication of emotion through facial expressions, microexpressions. But he identified 7 basic human emotions, and disgust is one of them. And I thought, that sounds like a really strong word, but that actually is an accurate way to describe what I felt in those situations, and probably many others. And it was sort of encouraging to read that that's not only normal, it's actually common, right? There's a purpose for the disgust reaction and response. Whether it's being applied correctly when we're applying it to patients is different, and that's sort of what I wanted to look at more in the article, but there's an appropriate and necessary function of disgust. So it alerts us to a potential problem. If something smells rancid, we probably aren't going to eat it. So it helps us to avoid potential dangers. Understanding that is a natural reaction, even goes into detail about the facial expressions. We would all probably recognize an emoji of disgust because it's so characteristic, the curled lip and the scrunched nose and sort of hunching down. He mentions all these different things about our response to it. And those can actually be hard to control. And for microexpressions, some people say they're impossible to control. But I may actually be communicating that to someone, even if I say the right things overtly, but I may have an involuntary response to a strong smell, for instance. So I kind of wanted to look at all of that and what part of this is something that I need to accept as normal it doesn't make me a bad person to feel disgust about lack of hygiene. But then what do I need to do to, and I think your use of the word bias is good, like being aware that that could bias me against somebody. So I may make judgments about their other aspects of their life and their O&P care that aren't accurate because I just assume they all go together.
Well, so what are some ways that you compose yourself? I imagine it's time and thought and kind of realizing your own emotions. But then how do you effectively educate your patient about the situation without showing a bias or any type of negativity?
So I think, again, I'm going to assume that my response is sort of falls within normal.
I would agree.
And even in terms of my answer to your question, that I think, and talking to other clinicians, I think a lot of these uncomfortable situations we just avoid and ignore, which is not necessarily a bad strategy, which I can get into later. I actually think most of this falls outside our scope. We're there for a very specific reason, and overall, hygiene is not part of that. So that's one strategy, is just be aware and don't feel like we have to address it. What often comes up with students is they're aware, I think, sort of instinctually, like we all are, that this signals a potential problem. And they want to get at the root of that. And this comes up with a lot of other topics. We've talked about suicidal ideation. We've talked about depression with patients. And we have to be really careful to not delve into areas that are outside of our scope. Don't open a door if you're not prepared to deal with what's behind there. So it doesn't mean we ignore it. There may be a need to refer. So say somebody, we've been caring for them for months or years, and we notice a steep decline in hygiene. Well, that could be a variety of things. They may have had a stroke that was undiagnosed. They may have had cognitive decline. They may have lost a caretaker. So we need to be aware of it to that extent. But in terms of actually therapeutically dealing with their lack of hygiene, I think that's out of our scope, except to the extent that it addresses their O&P care. So care of the device, including cleaning. Reality is most of our devices can tolerate quite a high level of lack of hygiene. But skin issues, so liners is a good example, where if liners aren't clear, prosthetic liners aren't cleaned, it's going to pretty quickly develop into a skin problem. So addressing those issues really specifically, and I give an example at the end of coworker Wendy Beatty, who most of the audience will be familiar with, was in one of these discussions we were having with students, and just the way that she talked, kind of quoting what she'd said to patients, I thought was a sensitive and very gracious way of making the focus about the device. So, for this to not cause problems on your skin needs to be soft and clean. So let's talk about cleaning your residual limb daily, but really restricting it to that and not speaking out of the frustration. But I can speak to keeping the residual limb, the body part, the device clean, and then talk really specifically about how to do that. I've had discussions with patients where they had skin irritation, and I use this example a lot with students. And I'll say, well, have you been cleaning your liner? Yes, I have. Like the way I showed you? Yes. Well, I can't really figure out where this irritation comes from. And in a couple cases, I said, well, why don't you come back in a week, and between now and then, write down every time that you cleaned the liner and how you did it. Like, do you use dial soap by your kitchen sink? Do you use a bar of soap? What do you use? And each time I've done that, the patient has come back a week later and said, well, actually, I wasn't cleaning it as often. So giving them, in a non-judgmental way, a tangible way of tracking, I don't think they were lying. They really believed they were cleaning it.
Right.
And then when they realized, oh, I have to keep track of this, they realized I went a couple days without cleaning it. So those types of practical things, but accepting as well that we're probably not going to change their overall hygiene pattern. And we take on a burden like that and we're not going to be successful. It just ends up being more frustrating for us. And again, that can be communicated to the patient.
Yeah, it's very interesting that it does lead down to two different paths, because you as a practitioner and everyone listening out there has to deal with this on their own terms and control their emotions, control their reactions. And that may be out of your control. So you really kind of have to focus on yourself in that manner. But the whole time you're also focusing on your patient for the clinical outcomes that you need due to some of their actions, right? And you got to just teach them down that pathway in a very open and accepting way and try to make the device work as best as it can for them. I didn't really come to that realization yet, but now I have, and I think that's super powerful that you're very accepting of your emotions and going through this process and writing this article and teaching it all the time. Like you use yourself as a case study so well that, hey, I may be reacting poorly at first, but or not poorly. Sorry, that's a wrong word. You know what I'm saying?
Yeah. Oh, yeah. And I think it is reacting poorly in many ways. Like the judgment, and I've used that word a couple times. Again, I don't think judgment's inherently bad. Like I could assess the situation and say, I see a problem here, and I judge that. That's not an effective way, right, to go about taking care of yourself or the device. But sort of judgment from the standpoint of condemnation. Like the reality is the patient has a right to choose to the extent that they are actually making a conscious choice. In many cases, they might not be. Being curious, not judgmental. That's been a mantra I've been saying to myself the last few years. Deal with the situation as it is. And what's the best chance of affecting some change? And it's probably not going to be coming on harshly to them. Even people who we would assume they're aware that they're not maintaining a say normal standard of hygiene are going to be embarrassed if it's pointed out.
Right.
And so they may not realize how significant it is, or they realize to some extent, but being aware of that very human reaction, a normal reaction, like it's an embarrassing thing to have someone tell you that you smell, and being sensitive to that. And I do think, that a while back, I think it was another educator, I heard them use the term aesthetic aversion. And in the context of sort of preparing students for, you're going to see things that you have an aversion to, and in a medical care context. And I've just come to believe that the more open we can be about those things, in, again, not making fun of somebody, not, using dark humor, but just being aware. I and I use this example all the time, I have a hard time with smells much more than sights. So there are people who pass out when they see blood. I can see almost anything. But a smell, especially if I'm not anticipating it, seems like a stronger effect on me than many other people. So being aware of that. So, okay, especially when it's a repeat patient and we know sort of what the pattern is. Okay, I'm going to see Mr. Smith, and typically he's not bathed, and take a deep breath before I go in the room and kind of get myself ready for that emotionally. It's not necessarily an issue I have to address each time.
I'll say, yeah, I think preparing yourself is like the kind of key there, because if you're trying to, like, your innate reaction is trying to say something to help them, but if you're doing that and it's not like quite your place, it's not really under your control, like you're gonna maybe be a detriment to their O&P care, which is your control and is your specialty. That's what you should be focusing on. So sometimes you have to just dial that back.
Right.
I was just going to say, we've talked with some people that have mobile practices, and just even something down to something, a person has the individual right to choose if they smoke or not. But sometimes a clinician is in a home where multiple family members are smoking indoors, and it makes it a very tough environment. I would have an aversion to that, and I don't know how I'd handle it, but I think most of all, I'd probably have to just get it done, right? And grin and bear it. But yeah, I think that's a very real thought process that you're going down, that this is a tough job at times, and you are going to have to cross paths with some things that you're just not used to.
Yeah, that's actually another article that I actually want to write, because clinicians have very different views on home visits. But one thing I've found is you get insight into somebody's life in a much different way when you're in their home. And again, same as with the hygiene issue, I just assumed everyone grew up and lived the way I do. And even though intellectually I know, okay, there's, different socioeconomic factors and other things, but going into people's homes and realizing when I give them instructions or when I describe a use pattern, I may be picturing a very different environment than what they actually live in. I need to be aware of that and not have that influence detrimentally sort of my respect for them or the dignity that I afford them, even if I wouldn't make those same choices or, wouldn't prefer that same environment. So I wanted to say something too about one of the things that Ekman points out about disgust is that the disgust response is reduced when we're around people where we have a genuine caring for them. So family. I've been thinking about this since I got the email about doing the podcast, because I'll see videos on social media of like dads changing diapers, and they literally have a hard time keeping it together and they're almost throwing up.
I'm one of them, buddy.
Yeah.
I'm one of them.
Yep.
My wife makes fun of me all the time.
So at the risk of too narrowly defining gender roles, it just is amazing to me that I've never seen that response from a mother. And I'm not saying that mothers love their kids more than dads do, but there's a different type of relationship and bond that for some reason that interaction, which in any other context in life would cause disgust, doesn't cause disgust. And clearly we're not going to care for our patients at the same level that we do a loved one. But I think that's a helpful way to think about it. That another thing that I challenge myself with is, if I'm having this response about somebody, checking sort of where my level of concern with them. And like I said earlier, is this frustration and this disgust about the inconvenience to me and my aversion to this, or is it a concern for them? And if they worst case scenario, they have a significant mental health issue or other things that incapacitate them, that should really, my response really ought to be concern for that and not disgust. I mean, there may be the disgust reaction, which, like I said, I'm okay with that being, or I'm reassured, I guess, that that's not an abnormal response, but I can act out of something else.
Yeah, it's like, the micro disgust for a moment, but then your brain is taking over with a macro more, this could be a health issue, safety issue.
Right.
Yep.
Cool. Well, it's been great talking with you, man. Is there anything additional you'd like to add about this?
No, I appreciate that you guys are interested in these articles and give them a little more wide play, and hopefully others sort of benefit from that, the perspectives that are in it. And like you mentioned, I do try to be pretty transparent about where I'm coming from on these issues, and hopefully by that sort of help other people feel like they can acknowledge some of these darker aspects of our responses.
Yeah, well, thank you so much for adding all of this knowledge and your perspective, because I do think this will very much help some people realize what's going on in their own brains when they're in that situation, So thank you very much for attending and being here, especially since it's multiple times, and we can't wait to have you back when you write some more amazing articles.
So SPS now I think accounts for 2/4 of the podcasts I've ever been on.
There we go. It's 100% of mine.
Yeah.
Awesome.
There you go.
Yeah, well, thank you, John. And I do really think it makes a big difference you using yourself as an example, because, I mean, a lot of times seeing your teacher, your professor, someone older than you, professing an idea, and you just think that they're perfect. They never experienced this. They're teaching you how to do it right. But you showing that you have been doing this how long, and you still have that like natural guttural reaction, and you know how to approach it after that, I think it's really, really helpful.
Yeah, great.
If you'd like to read the full article, connect with John on LinkedIn, or learn more about his work at Northwestern, follow the link in our show notes.
Thank you for listening to the O&P Check-in, an SPS podcast. We hope you enjoyed the episode, and if you did, be sure to leave a review and subscribe to the show on Spotify, Apple Podcast, or wherever you listen to your podcasts. Have a question or topic suggestion? Email us at spspodcast@spsco.com. See you next time.